Thanks, James.
Okay, thank you very much. Thank you for everybody turning up. So my name's James. I'm a trainee ACP, so advanced clinical practitioner, working in South Bristol, stroke subacute rehab unit at the moment. And I'm also co-founder of a private physiotherapy and coaching business called Neuro, which is kind of based in South Wales and in Bristol then. So that's kind of my experience. So apologies, I've got like 3 screens here, so I'm going to have to look at the furthest one away. So apologies, I won't be looking at the camera. So today I'm here to talk about post-stroke shoulder pain. Now, this is a super complex topic. So this is kind of a bit of a whistle-stop tour. I've got a bit of a feedback form at the end, which would be great if you could fill out, but it does kind of say if you'd prefer something a little bit longer, then we can look to kind of do that at a little bit of a later date then.
James, sorry,
yes.
there's just a little box on your screen. Can you just tick the hide thing so it disappears? Thank you.
There we are. Is that okay? Is that gone?
Yes, sorry, that's great. Thank you.
Great. So what is it? So basically, it's any pain that develops in the shoulder which has been affected by the stroke. So really broad kind of term. So why is it important then? It's linked with poorer outcomes. It's got a higher rate of depression in people who develop post-stroke shoulder pain. And if you develop it when on a rehab unit, it has actually shown that people are less likely to return home and actually go into care homes. So depending on which study you read, it sort of affects between 20 to 50% of stroke survivors. That number can be as high as 70 to 80% in some studies if we're looking at rehab settings. And that's mainly because people are more severely affected who need to go to and spend some time in rehab settings. And that's a risk factor for developing post-stroke shoulder pain then. And the median time that it occurs is about 4 months post-stroke. So if we lined up every stroke survivor who developed post-stroke shoulder pain, then that middle person would be at 4 months. Obviously, there's a wide scale of that, but that middle person is at 4 months. So why does it happen? So it's a multitude of different reasons, and the reasons we're going to explore today is muscle weakness or subluxation, spasticity and muscle imbalance, joint and soft tissue problems, and sensory and neurological factors. So we're going to try and look at why does it happen, how do we manage it, and how do we prevent it happening for each of those different reasons. So if we start off with muscle weakness and subluxation. So our shoulder is built for movement and not stability. So it has the most amount of movement of any of our joints in the body, but therefore it then has the least amount of stability. So we have firstly static stabilizers of our shoulders, which is our ligaments, which are all shown in that picture. We also have a shoulder labrum, which is kind of a ring around the shoulder joint, which makes the joint deeper. And then we also have a capsule, which is basically like a big bag around the shoulder, which kind of sits there and gives it a bit more stability. We then have dynamic stabilizers, such as the rotator cuff. Most people would have potentially heard of that. And a couple more muscles then, such as the posterior deltoid and the biceps, which also help sort of actively stabilize our shoulder. And these muscles, their job is to hold that shoulder in the joint while we then do all the kind of fancy movements that we can with our shoulder. So when we have weakness of them dynamic structures, so the rotator cuff in particular, and we have a loss of function to these, then we tend to get a subluxation. So the weight of the arm, which is around sort of 5 kilograms, pulls down sort of and lengthens the static structures, so the ligaments, stretches the labrum and the capsule, and this can in turn cause some pain because of that stretching. And when you get that kind of stretching on them structures, you also get a bit of stretching on peripheral nerves around that area, which again can cause some pain. Now, there's a little bit of a debate about whether subluxation is associated to pain. And when you kind of look at the studies, about half of the studies show that there's a link between subluxation and pain, and half of the studies show that there is no link. So kind of the jury's out on that one. But this is kind of how it looks. So you have a normal shoulder joint and the top left-hand screen. You then get a little bit of sort of pulled down from that arm bone and a little bit more widening. You then get to a moderate subluxation where you're kind of, that shoulder is kind of really stretching on that joint, and then an advanced subluxation where the kind of the shoulder isn't in the middle of that shoulder joint then. And then we have dislocation, which isn't normally a problem post-stroke. So how do we manage it? So the first line is through therapy. So strengthening, taping of the shoulder, and neuromuscular stimulation, alongside regular pain relief and good shoulder positioning. So you can see some rotator cuff strengthening there. You can see some taping that potentially can be used to sort of support that shoulder. That's a kind of rough position where we tend to put electrodes for neuromuscular stimulation to help sort of get a little bit more activity into that shoulder. And then there's some nice positioning sort of at the top, what to do and what not to do then. So you can see that slings aren't actually on there. So slings have been shown to be ineffective in fixing subluxations. And then the other kind of thing that we can use to manage it then, if you do have pain because of a subluxation, if it remains for a period of time and is significant, then we can look at kind of steroid injections then as well. So how to prevent it? So it's very similar to what we talked about in regards to how to manage it. So strengthening and positioning are really important. However, if there is no function in them dynamic stabilizers, it's very difficult to stop it happening. And we just kind of go on to that management part then if we see that is happening. It's really important that we do try and prevent or we manage it well, because when them kind of ligaments and the capsules start to be stretched, it takes a long time for them to shorten again. And when we get that stretching, we also get stretching of the muscles, which then also make them really difficult to activate. Our muscles want to be kind of at the optimum length to activate. And when we get that lengthening in them, they struggle to activate. So the strengthening then becomes more difficult. And then when obviously we talked about the peripheral nerves, when they get stretched and damaged, this can result in less sensory input coming through the shoulder, which then means that you potentially then again make it harder to strengthen because you get less motor output. And a subluxation kind of predisposes you to other pathologies such as frozen shoulder or chronic regional pain syndrome. And we'll kind of go on to frozen shoulder at a different point then. So that's subluxation. If we move on to the next topic then, which is spasticity and muscle imbalance. So firstly, why does it happen? So damage occurs in the brain, as you can see at the top of that picture, where you kind of got that red sort of splat, which is meant to be a stroke. Now, sometimes they will impact the nerves in the brain that tell our muscles to contract and to turn on, and that's where we get weakness post-stroke then. And sometimes they can also affect the nerves in the brain that tell muscles to calm down or to switch off. We call this excitation, which is turning on, and inhibition, which is turning off. So as shown in the diagram between the plus and the minuses. So spasticity happens when there is damage to these nerves that tell the muscles to turn off. So we don't get any signals coming down into the muscle from the minus signals. We naturally then have a normal stretch reflex in our body. So when we get that stretch reflex, our muscles will contract, and then our signals will send down to that muscle to then tell it to turn off. Now, after a stroke, if them signals that say turn off are damaged, you will continually get them plus signals then. So you will continue get the signals to say contract, turn on, and that muscle never gets told to turn off. And when that happens over and over and over again, we then get spasticity developing. And this is kind of a typical upper limb spasticity picture where you get internal rotation and adduction of the shoulder, flexion at the elbow, forearm pronation, flexed wrist, a tight clenched fist and thumb then as well. So when that happens, that can cause shoulder pain by pulling the joint into an abnormal position. This puts strain on the muscles and the joint and the capsule, again, can cause pain. The joint becomes then harder to move. It makes it stiff and inflamed. And then when we do move it, it's painful. And then the soft tissues can become irritated. So the constant overactivity in these muscles make them tight, irritated, and difficult to move, and then also painful to stretch, causing shoulder pain. So how do we manage it? So firstly, we need to address triggers. So triggers that can make spasticity work are pain, sort of skin damage, bladder and bowel problems, infection, mental health and mood, fatigue, and then kind of temperature and your environment. So if you're in a very stressful environment, that can make spasticity worse. So this is extremely important. This part of the management is because anybody can do it. So either if you're a stroke survivor, you know yourself best, or you know the person that you're caring for best if you're a carer. So you can see that increase in spasticity normally that can then develop into shoulder pain. And firstly, try and address, okay, what may be triggering this worsening in spasticity? Do they have an infection? Are they constipated? Is their mood a little bit low? And trying to manage them scenarios to sort of dampen down that spasticity and not let that develop into any shoulder pain then. So next is movement and strengthening. So we look to try and strengthen the muscles that counteract that spasticity. So normally we see it in what we call the flexors of the arm. So our anti-gravity muscles, and we look to then strengthen the extensors. And by doing that, we can get more relaxation into that muscle then. Neuromuscular stimulation can be beneficial. So some studies have shown to help reduce it, but I'm not sure that that's actually in the stroke guidelines, but studies do show that it does reduce spasticity. We've then got medication. So painkillers can help with the trigger of pain. So if pain is worsening spasticity, it's important to potentially get that looked at. And what can happen then is actually because pain triggers spasticity, if spasticity starts that pain cycle and then we don't deal with it, spasticity gets worse, it makes that pain worse, and you get into a cycle then that kind of results in severe shoulder pain. Other medications are kind of antispasmodic. So the sort of most popular one used is baclofen. That can help to relax muscles that are problematic because of spasticity. And it can help if spasticity is driving the pain, but there's not a lot of evidence of that alone making a big difference on post-stroke shoulder pain. So it's making sure that we do all the other bits around it. Botulinum toxin, however, most people know as Botox, does have a lot more stronger evidence, and studies do show improvements in pain, function, and quality of life. And the evidence is just getting stronger for this and doing this early. So when we say early, the kind of first 12 weeks of stroke. However, there is sort of at the moment a huge disparity in services across the UK. So you'll notice on here, stretching isn't on there. Now, there's not much evidence that shows that kind of passive stretching or splints are guaranteed to help spasticity just alone, but they normally are helpful and can work as sort of alongside other treatments that we've listed here then. So how to prevent it? So unfortunately, you're unable to prevent it because it's mostly because of kind of where the stroke is. And then there are other factors such as kind of more severe strokes and more related to spasticity, more profound weakness. Younger people tend to develop spasticity more than older people who've had a stroke. Sensory loss, neglect, and then the area of somebody's stroke, so the internal capsule, the basal ganglia, brainstem, or motor cortex then. And then kind of preventative measures of it causing shoulder pain are everything we've discussed in the earlier side. So addressing and managing triggers, movement strengthening, neuromuscular stimulation, medications, and then botulinum toxin. So that's spasticity. So moving on then to joint and soft tissue problems. So firstly, why does it happen? And we're going to break these down into two different sections. So the first is frozen shoulder. So the general population of people who develop frozen shoulder is about 2.5%. Now the stroke population, again, depending on what studies you read, is between 43 and 77%. So there is a huge risk factor of developing frozen shoulder if you've had a stroke. So this happens where certain static stabilizers of the shoulder, mainly the capsule and some ligaments around the shoulder, become tight, thickened, and inflamed. And you can see in that picture that when they become inflamed, it kind of makes that capsule tight and then can cause pain when we look to move it. It's mainly caused because of lack of movement of the joint, but there are other factors that put you at risk, such as weakness, lack of proprioception, so your awareness of where your arm is within space, people who have diabetes, and then things we've talked about before, so subluxation and spasticity are also risk factors for developing frozen shoulder. So it shows a severe stiffness of the shoulder and has a specific pattern of stiffness. So it tends to be abduction, so moving your arm out to the side, internal rotation, so the movement inwards of your shoulder, and external rotation, so the rotation out of your shoulder. It has different stages of the disease process, but we kind of don't have real time to go into a lot in depth of that today. So how do we manage it? So stretches and strengthening. So on the picture there, you can kind of see some general stretches that are promoted to be done when somebody has a frozen shoulder. You can have steroid injections for this. There's a procedure called hydrodilation, which is where they inject fluid into the capsule to help it expand. They usually put a bit of a painkiller in there, so it reduces the pain and it can improve the movement of that shoulder. And then kind of for severe painful frozen shoulders, we can do nerve blocks. And then in kind of the most severe of cases, surgery can be done. But frozen shoulder tends to last a long period of time. So that sort of surgery is considered only really late. And what they do there is kind of a capsular release where they kind of cut the capsule and try and expand it, basically. And then also manipulation under anesthetic, where they put you out and they just yank your shoulder to try and kind of break up all that scar tissue in there. So how do we prevent frozen shoulder? So trying to keep the shoulder moving, protected, and supported. So movement-wise, so we're looking to try and take that through range of movement as tolerated. And again, the more early you can do that, the better. Good positioning and support, so we don't cause any trauma to that shoulder, especially if it's significantly weak. And then the things we talked about earlier, so if you have risk factors such as a subluxation or spasticity, trying to manage them as best as we can. So supporting the shoulder, trying to strengthen their muscles to help that subluxation. And then spasticity, making sure that we get a good range of movement to that shoulder and good positioning then, so we're not kind of stuck in one position with that shoulder not moving for long periods of time. So the next thing is subacromial pain syndrome. Now, this is a bit of an umbrella term for multiple different things. So it incorporates a rotator cuff tear, bursitis, supraspinatus tendinopathy, or tendinitis, some people would call it, which is part of your rotator cuff, and then biceps tendinopathy as well, or tendinitis. So all these are kind of caused by similar issues. Again, it's kind of can't go into all of them in depth together, but they tend to show up as what we call a painful arc. So as you move your arm out to the side between kind of 60 and 120 degrees, that movement will be painful, and then it'll actually be okay above 120 degrees, and it'll be okay below 60 degrees, roughly. And kind of what was taught previously is we thought it was due to kind of more of an impingement, but it's more that painful arc happens because that rotator cuff is being put under the most load through that 60-degree range of movement. So kind of roughly to say why it causes it. So a rotator cuff tear is normally too much load or trauma. So our rotator cuff tends to get a bit weaker once we get older. You tend to get a bit of tendinopathy in there, and things like falls can damage rotator cuffs then. Bursitis happens because of inflammation of that bursa, so that little blue sac that you can see there on top of the that shoulder joint, that becomes inflamed and can cause pain. And then tendinopathy can be caused by either not enough loading of a tendon, so where you're potentially not moving your shoulder because of weakness post-stroke, poor movement of the shoulder, so kind of a muscle imbalance and poor kind of movement technique, or too much load to one of them tendons then as well. And then other risks sort of for all of them are kind of alignment changes, muscle imbalance. So things like, again, what we've talked about, subluxation, spasticity, and weakness then. So again, we're not going into the specifics of how exactly we manage each one, but again, roughly, therapy tends to be the most important thing. Now, these can be really tricky to manage, and you likely will need guidance on kind of appropriate strengthening exercises and appropriate kind of loading and guidance to kind of exposure of these painful ranges, alongside kind of scapular mobilizations and taping then, which we've kind of discussed before. But education is also really important for this type of pain, because it can take up to kind of 12 weeks to see improvement. So kind of it can be a long slog in regards to trying to get the right management plan in place and sticking with it for a long period of time. People can have steroid injections then to help with these. So if it's kind of not budging, or if it's significantly really painful and potentially your physio, your GP offers this, then you can have steroid injections, which kind of last that 3-month period to them 12 weeks to try and sort of help you do potentially some of the exercises or work in them painful ranges then. Things like painkillers then will also help with that. And how to prevent it. So the most important thing is good movement quality. So we speak a lot about this in stroke recovery when we're kind of looking at returning movement and trying to do the correct movements. It's not always possible because of people's weakness they get around the arm, but that kind of muscle imbalance and that poor quality of movement can be a big reason why this type of pain happens within post-stroke shoulders. Strengthening then is really important. So again, making it sure it's kind of progressive. You don't want to overload that tendon, especially if you've had a period where it's been very weak and you haven't been able to sort of put a lot of load on it. And when I talk about load, is kind of movement, strengthening, kind of weight bearing, things like that. So you want to make sure that we're progressively loading that. And then alignment issues is kind of a big problem. So if we think about kind of, again, the reasons we've talked about before, and there's a little bit of a theme here where a lot of things link into each other. If you've got a subluxation or spasticity, that can cause a poor alignment or a muscle imbalance due to kind of weakness or spasticity. These muscles start to move in ranges then they're not used to. That can put more tension or load on these muscles, causing that tendonitis. Or if they're kind of moving, or that shoulder's moving differently, it can kind of irritate the bursa, cause that inflammation, cause a little bit of bursitis then. And then obviously if we have muscle imbalances that are causing that, making sure that we're kind of strengthening weak muscles, stretching tight muscles, so we get that good alignment then. So that was kind of joint and muscle issues. So the last one then is sensory and neurological factors. So why does it happen? So basically neuropathic shoulder pain or neuropathic kind of stroke arm pain happens after a stroke because of the damage in the brain's pain pathways. So the brain then will send mixed up or exaggerated pain signals to the shoulder, even when there's nothing sort of wrong with the shoulder itself. It can typically feel like a burning, electric shock pain, or extreme sensitivity. And what we see is an increased prevalence in strokes that happen in the thalamus and the medulla. And also if you have sensation changes post-stroke, then that can be a risk factor of developing neuropathic pain. It can be continuous, so they're all of the time. And some people sort of say that it's worse at night. So you can kind of see from that picture then, so you get the damage to the brain, you get impairment of them descending pathways, so the pain signals, you then get an abnormal signal to the peripheral nociceptors, so the nerves that say, oh, we're having sensation here, they get sort of sent up to say, oh, we're having sensation here. And the brain basically interprets that as pain rather than something like light touch. And then the brain goes through something called, and the spinal cord go through something called central sensitization, where the nervous system becomes oversensitive. And then you get to the point where you just get light touch, or like I said, nothing is actually anatomically wrong with that shoulder, but the signals that are being sent from it to the brain are being interpreted by the brain as pain. So how do we manage it? So we need to try and calm them overactive pain pathways in the brain. So the first kind of management of it is desensitization. So through this, what we're trying to do is provide normal sensation to the arm or the shoulder. So that can be done by kind of light touch. So there's sort of an example of using a towel there on your arm and different sort of textures to sort of show that actually this is normal sensation for that arm. And things like weight bearing through that shoulder then become really important, just to give it more normal sensory input. Things like mirror therapy can work really well. Again, functional use of the arm is all about getting normal movement and normal sensation through the arm. And that kind of needs to come with a bit of an educational sort of piece where a therapist may have assessed that shoulder and said, actually, we can't find anything wrong with it. There's no range of movement problems. We can't see any muscle imbalances. And actually, we think this has the hallmarks of neuropathic pain. And actually, there's nothing wrong with the shoulder. We can move it. It's okay. Because when we get pain, we then tend to not move and not move into that pain, which would then worsen that kind of oversensitivity of the nervous system. and kind of cause more problems, such as things we talked about, frozen shoulder and subacromial pain syndrome then. Psychology can tend to be quite important in that kind of educational piece as well. That can really help. There's neuropathic pain relief medication out there, which can kind of take a little bit of the edge off that pain. But again, it's making sure that when we're using that, we're not just using that, we're making sure that we're doing all the other techniques listed above. And then there are sort of things, again, more severe cases, there's nerve blocks and TENS can be useful. And there's also TMS, which is transcranial magnetic stimulation. So I've never actually seen this, but there is kind of an emerging market for it. So I thought I'd put it in just in case anybody has heard of it before. But basically, it's magnetic pulses to stimulate different areas of the brain. And there is some promising evidence of it having a positive effect on neuropathic pain post-stroke. But it's kind of very limited availability for people. So I don't know of anywhere that actually has it personally at the moment. So how do we prevent it then? So it can't always be prevented. So again, a big risk factor is the area of stroke that you have it. So when we kind of have it, it's making sure going through all their management sides. But it's also really important that actually we get good sensory stimulation through that arm. So we kind of get normal light touch, normal weight bearing, normal movement as much as possible then. And then managing other issues which can then sort of increase the risk of neuropathic pain, such as general pain in that joint, spasticity, and sort of preventing trauma. So kind of treating them so we stop that nervous system becoming oversensitive. So that's very much a whistle-stop tour of everything. So in conclusion, and I'm sorry if that was a lot of information, post-stroke shoulder pain happens to a lot of stroke survivors for many different reasons. It can be severely debilitating, impacting on recovery and quality of life. There's a lot of overlap, if you've seen when I've sort of discussed things about the risk factors for different reasons for why pain happens. So such as spasticity being a risk factor for a frozen shoulder, and also subluxation with that as well. And most can be managed with therapeutic techniques, movement, and simple painkillers. But obviously, if that's not helping, then it's making sure that you're seeking advice with kind of worsening or severe pain. And that can be either your therapist or your GP normally. That we can't always prevent it. So if it happens, it's not a case of that you've done something wrong or it's not been managed correctly, but things like good positioning, support, good movement techniques, and strengthening can help to sort of overall prevent post-stroke shoulder pain then. So thank you very much for listening. There's a QR code, and I think there's potentially a link going in the chat as well about kind of a bit of a feedback form. I think there's only 4 or 5 questions, so it'll only take you 2 or 3 minutes to complete. So if you could fill that out, that'd be great. And kind of let me know if you feel like I've missed anything, or would you like anything further if that's kind of too whistle-stop tour for you. So yes, any questions?